I'm a registered dietitian.
I'm an exercise physiologist.
I'm a cardiologist.
I'm a clinical pharmacy coordinator.
I'm living with heart disease every day.
And I live with coronary artery disease.
Diagnostic tests are used to help us decide what a particular symptom is coming from. With testing, we start out looking at things that are very low risk for the patient and give us some discrete numbers as far as risk and gauging risk. It's all about estimating risk, really. And so we look at things like blood pressure, cholesterol, heart rate. We look at family history and things like that we can assess without doing anything terribly dangerous to the patient. And then if they have symptoms and then they have something questionable with their risk, and the symptoms are compelling, we can order other tests. So there are non-invasive tests and there are invasive tests. Non-invasive tests are ways that we can look at a patient's particular symptom or cluster of symptoms and risk factors and decide, do we need to move on this and do something invasive and riskier? Or is this something that is stable and we can modify risk factors and this person will be okay? Non-invasive testing involves not inserting anything other than a blood draw or an IV into the body. That's running on a treadmill, doing a stress test, getting a pharmacologic stress test, taking a picture of the heart afterwards. An echo, getting an ultrasound of the heart, getting an EKG, that's non-invasive. An EKG is a test that involves putting stickers on the chest and looking at the electrical pathway through the heart. It's non-invasive and fast and completely painless. Stress tests are tests that look at what happens to the heart with exercise, or what we call stress. So we put people on a treadmill, get the heart rate up, the blood pressure up, and then we look at how the heart handles that. And then there are pharmacologic stress tests for people who can't run on a treadmill, where you have some medication given through an IV to simulate that stress, and you have pictures taken before and after. An echocardiogram is an ultrasound of the heart that looks at the heart structure and function. It can look at the valves. It can measure chambers. It's good in many respects, and it's good as an adjunctive to stress tests. An MRI is a giant magnet that looks at the heart without any radiation at all, and it's a very clear picture of the structure of the heart and can look at the valves and chamber sizes very well too. A CT scanner can be used in a couple ways. One way is just looking at the calcium score. So if you have calcium deposition in your artery, you can catch that. So we know that there's cholesterol plaque in that artery. We have some other CT scans for the heart called CT coronary angio, where you get an IV inserted and you get IV contrast or dye. And the CT scan of the heart is timed for when the dye reaches the coronary arteries and then snaps the picture then. And that gives us a picture of the arteries themselves. It tells us not only is there some calcified plaque in there like the other CT scan, but it tells us, is there soft plaque, non-calcified plaque, which is fresher and actually more dangerous, and it tells us how much blockage there is, or if there's any blockage. Invasive testing is something that involves a risk, a larger risk, such as heart attack or stroke or death from the test. A coronary angiogram is an invasive test, and it's what we consider to be the gold standard test. We can squirt a puff of dye directly into the coronary arteries using a catheter that's in the aorta inside the body. And an X-ray camera takes a picture of the artery as the dye is going through. And it's a very clear picture. It's the best way we have of looking at this. And then if there is a blockage there, we can open that with the same procedure with balloons and then stents. Stents are little teeny tiny little wire mesh tubes that we insert over a wire and a balloon and inflate the balloon and deploy the stent that way expand the stent and prop the artery open. Sometimes it's not safe to fix blockages with a stent. Sometimes there are too many blockages, or the heart is very weak, or one of the main arteries is blocked in combination with many others. And working on one area with a stent would be way too high risk. And in some cases, we recommend that patients have coronary artery bypass graft. And that's open heart surgery where the blockage is bypassed by using either a vein or an artery in the chest. And the vein is sewn from the aorta down onto the coronary artery past the known blockage, thus the term bypass. Women with known coronary artery disease, meaning they've had blockages in the coronary arteries or heart attack in the past, the most important test is actually what's done in the office every day, which is blood pressure, heart rate, and cholesterol. Exercise is very, very important, not just in keeping your heart healthy, but it also alerts you to the fact that something might be wrong. If you're used to regular heavy exertion, you will know at an earlier stage in the disease or in the process if there's something wrong than a sedentary person would. In general, we don't go ahead and do tests unless there's a problem or a question. And so if you know your body and there's some kind of a change, symptoms can be checked. And there are things that we can do to rule out an impending coronary event or rule out coronary disease. And so if you're having some new or different symptoms, and functional symptoms, meaning things brought on by activity, those are very important to assess on a timely basis. My name is Dr. Betty Gray. I'm a cardiologist with the Minneapolis Heart Institute.